And for those of you who've never met me before, the first thing that will probably strike you is I'm not a native of Sydney. I did admit to both Dianes that I get a little bit excited when I talk, and sometimes I forget the time. It's a big clock there, so I'm going to try and keep my schedule. And it's just as well because I've got my distance glasses on and not my nearsight glasses, so that's quite good that it's very large. Anyway, thank you to the organisers and to the committee for inviting me to speak. This is a topic that I'm absolutely passionate about. Paediatrics is my first love. I first decided to become a paediatric nurse 4 days before my 4th birthday. And the story is really, this is me, I do sidetrack all the time, but I will come back on track. But I think it's important to reconnect with why we want to do what we want to do and to remind ourselves of that. And a couple of years ago, I kind of was reminded of that when I was asked about what drives my passion. And I remember being back to that almost 4-year-old child and being in hospital myself. And there was 2 incidents that happened, and I can have a vivid memory of it. It was, as I say, just before my 4th birthday, and I was going to have an operation on my leg because I'd had polio as a very young child. And like those days, your mum had to leave you in the hospital all on your own. And it must have been quite frightening, I think, and I wet the bed. Now there's the confession already. That's not the story, that's not why I decided to become a nurse. I wet the bed and a nurse came up to me and I was crying because I was embarrassed because I'd wet the bed because I didn't normally wet the bed. And I asked her for a drink and she told me that paedo beds don't get drinks. And I remember feeling really, I couldn't put a word on it, but I think I probably felt humiliated and was made to feel really small. And it kind of felt like an injustice that someone in health who's there to care for patients would treat someone like that, an almost 4-year-old child. Now my story, of course, is not unique. Interestingly, there's another part to the story, well, 2. She took my doll off me. My mother had given me my birthday present early. We were quite a poor family, we didn't get much, and I got a very politically incorrect nowadays black doll. I just loved that black doll. The nurse took the doll off me and I never got it back again. And the next day, my mother came to see me and she was allowed in because my operation was in the afternoon, so she was allowed in. My sister, who's 10 years older than me, wasn't allowed in because only parents could visit. So she was sitting outside. And my mum came in and she said to the nurse, not the same one, of course, she said to the nurse, why is her leg painted brown? And the nurse said, well, because she's going for an operation on her leg. That's the cleaning fluid, betadine, obviously. And my mum said, yeah, but it's her left leg, and it's her right leg that's the problem. And the nurse said, no. See, here it says on the operation she's having it on her left leg. And my mum said, but she doesn't have a problem with her left leg. But it was written down, and so for that nurse, that was the truth. And so luckily my sister was there, and she ran 1 mile home to collect my caliper that I wore and bring it back to prove that it actually was my right leg that was the problem and not my left leg. So these 2 things have actually come together for me in really my passion around involving families in the care of their child and believing families when they tell you something about their child, because after all, they know them best. But getting back to that nurse, I trained in the same hospital. It was 15 years later. She was still there. Her name was Veronica, and she was still cruel to children. But she was quite clever. She only did it when she thought no one else could see. And so I think that's what drives my passion, because people like Veronica need to have feedback that that's not acceptable. And so I'll get on with my talk now. So now that you know a little bit about me and why I'm really passionate about the kinds of things that I work with and working with patients and families and staff. Okay, so I work in the Nursing Research and Practice Development Unit at the Sydney Children's Hospitals Network. And we established the unit in 2005, just as I was completing my PhD. And really, the main thing that I wanted to talk to you about in this unit is we set up the unit in order to work with staff to help them look at their practice. The whole idea was not to work on people to make them change, because actually that doesn't work. So it was about working with clinicians to help them investigate and look at their own practice and think about how they were doing that in terms of the evidence around their practice and how they might improve upon that. So the whole philosophy was one of working with people rather than on people. So some of you have already probably know quite a bit about practice development, but for those of you who don't, I thought I'd just do a quick whistle-stop tour of what my understanding and how I work with practice development. So you can see from this slide that practice development is really that continuous process. It's a continuous process. It's not a one-off thing. Someone comes in, works with you to change something, and then leaves you again. Practice development is an ongoing process. It is supported by facilitators like myself or like other clinicians who really want to work with individuals and teams in the clinical setting. So it's not about experts here. It's about clinical staff having the expertise about their own practice. It does take tenacity and creative imagination to help people look at the possibilities, because sometimes we've forgotten what is possible. The learning that occurs through doing the work that I do brings about transformations in individuals and in teams as they become more aware of the everyday context of practice. And the practice changes that we do are embedded in both the processes of undertaking the practice change and the outcome. But it also needs to be supported in the organisation. There's no point in beavering away at something over here if the organisation's not on board to help support change. Now, of course, we're very familiar with technical approaches to developing clinical practice. And a technical approach, for example, if we take, for example, this is, we're looking at paediatric and kind of critical care areas. So if we take one of the very basics of crit care, or any kind of work, is around about delivering effective CPR. Now, when there are changes in how to do that, and some of us are perhaps as old as me, have gone through some of the changes over the years, when you actually introduce a change there, you're probably going to take quite a technical approach to introducing that change. Okay, so how we train people to undertake CPR, basic life support skills, is going to be fairly universal. And there'll be guidelines come out, and organisations will adopt these guidelines, and the changes will take place over the coming months. And that's a fairly technical approach. What you're really interested in is getting all staff to a very basic standard of how to undertake CPR. If we were to use the same approach, and by the way, the evidence says that although we undergo yearly CPR, who does their yearly CPR assessment? You know, we undergo that. Unless you're actually working in an area where you're actually doing those skills on a regular basis, after 2 or 3 months, you've forgot those skills altogether. So the evidence actually shows us that yearly appraisal is not actually going to do that much. Anyway, that's another story. But if we look at transformational practice development, what we're really interested in is looking at what's happening. We're looking at the research evidence, but we're also looking at other kinds of evidence in and about practice. We're really more interested in the process of how you get to the change and learning through that process and building skills with staff about the process of the change as much as the change itself. The development of staff is key in this kind of approach. The changes that we're often working on are practice-driven rather than driven from external sources. And the interventions are linked to the processes as well as the outcomes. We're really interested in finding out what works in delivering that change. And this is informed by
an approach called critical social science, and a really simple way to take this approach is, in everyday practice, we often no longer see a significant amount of what happens in front of us because we just take it for granted. And we do this because to keep everything in the present moment would mean that our brains were even more scary than they are currently, trying to juggle information. And so in life we do this. Who here drives a car? Most of you? I wonder, for some of you, when you learned to drive the car, you perhaps learned in a manual. Can you go back to that time when you were learning? And I remember when I was learning to drive a car, it was really quite scary trying to remember how to do the clutch and the brake and change the gear. And you had to look in the mirror, and you had to look, and you had to steer, and you actually had to move. And it was really quite freaky in those first few lessons, thinking, I will never get this. And now, I think for the majority of you, you often drive from A to B without ever consciously thinking of all the steps that are involved in driving a car. So how does this relate to practice, you say? I'm currently working on some medication safety research work. And what we've done is we've outlined that there are 50 steps in medication administration from the time the script is written to the patient getting the drug. And hopefully the right drug, right dose, right route, etc. But that means there are 50 opportunities to get it wrong. And if you think of the drugs that you do every day, so we've been doing some averaging with our staff, and some of them are giving 50 drugs in a day, times 50 steps. Can you start to see how the volume? It's no wonder that sometimes people take shortcuts in being present and just do it. So when you step back and ask people to look at it, they can often not even tell you what it is they've been doing, because it's just a script, they're following it. So what Brian Fay says about this is that we need to raise our consciousness to the everyday so that we can start to look at what is it that we're actually doing in everyday practice. Once we start to raise our consciousness to that, we start to see things that we think perhaps don't fit with how we want to be as practitioners or how we want to deliver care. Now, often these conversations about what's not working in a clinical area happen every week. If you're in the tea room, there'll be someone there complaining about some system or process or some approach or some person that is not following the way things should be done. But the problem is the conversations often end there. And what practice development does is it gives you an approach to helping you see how you can act. And if no one acts, nothing ever changes. And so the work that we are doing is about when people feel that something needs to change, it's about giving them the courage to act on those things that are sitting uncomfortably for them. And the final stage of this approach is emancipation, not the kind of Emily Pankhurst emancipation, but more that you have the freedom to act, that you know how to navigate the systems, that you are able to use these approaches to help you act. So again, this is just an outline. Becoming aware of what we do and how we do it. Developing an awareness of the system and how that impacts and influences. Identifying the contradictions between what we say we do and what we actually do. And this is quite interesting work, and this is part of my PhD where I worked with nurses in the special care nursery. Every one of them identified that they were a family-centred care practitioner. To do otherwise is really kind of like, oh, we're here because we really care for the patients and their families. But once we started to look at and observe practice, what we actually found was more a nurse or midwife-centred model of care, where parents were seeking and given permission to engage with their infant. But staff didn't see that because they just took for granted that what they were doing was family-centred care. So sometimes in this work it can be quite painful when you stand back and realise perhaps there's a contradiction in what you've been saying. I'll give you an easy example of a contradiction. I'm sure that every one of you would identify with being a person-centred practitioner and being there for your patients, your clients, your consumer, or whatever you call the patient population you serve. But often I hear conversations, and I heard one a few weeks ago when I was in an emergency department with a friend. I hear conversations around bed numbers, around disease processes, and less so about who the person is that has that disease. In the emergency department, a young doctor, I was sitting with my friend, he was waiting to go for an endoscopy, and I heard a young doctor saying to the nurse, "Number 9's due for endoscopy now." I thought, number 9 is Adrian. He's my friend. He's got lung cancer. Shit, he's not number 9 going to endoscopy. He's Adrian. And so I think people don't get that actually being there for patients is little things. Luckily, my friend Adrian's gone a little bit deaf with the chemo, so he couldn't hear the fact that he was number 9 going to endoscopy. But everyone sitting around his bed did. And so how does that make you feel? Now, I'm not saying that doctor did that intentionally. We do shortcuts. And sometimes in those shortcuts, we become more distant to the patient and their family. So critical social science, emancipation, it's actually about changing the practice that we do to reflect what we believe in here. And if what we believe in here is that we are truly here to be for patients, then how does our language reflect that? How does our actions and our inactions reflect that? It's also about generating knowledge about what is working and what is not working, and actually acting upon that. The conceptual framework that I work with is this one. It's really about connecting back to what nurses and others, because we don't just work with nurses, what they value and believe about practice. It's about being clear about their role and how that sits within the team context. It's interesting that a lot of issues that occur between staff members is when they're unclear about what their role is compared to someone else's. And when there's a clash because someone else is doing what I think is my job. That my patient, my child, that language in itself is distancing. But it is also about learning in and from practice. The best place to learn about being an effective person-centred practitioner is in practice, working with real stories rather than something abstract. But it is also about having systematic approaches in order to help us to change. So practice development methods use the principles of CIP, SIP, which is working collaboratively, inclusively and participatory, not working on people to change, but working with people to come up with ideas that they want to change. It is about developing person-centred cultures, learning in and from practice, using and developing knowledge and policy, evaluating practice change on an ongoing basis. I'm sure every one of you could tell a story of a change that came into your practice, and you look back 6 months later and it disappeared. Where did it go? What happened? And then when some bright spark comes up with the change in another couple of years and says, why don't we do this? You go like, oh, we did that. We tried that. It didn't work. The thing is, in order to actually get change in practice, you need to have an ongoing systematic approach. It's not a one-stop shop that fixes everything. And so if you're not actually looking at and evaluating that practice change, it's all too easy for it to disappear. It's also about facilitation and leadership. This is the person-centred nursing framework that I've been working with, and I am going to break it down a little bit for you. However, I'm going to share with you the most up-to-date version. This is the person-centred nursing framework, which is actually just being published this year in the person-centred nursing book. It's only just been launched perhaps about a couple of weeks ago, and there are not that many differences from the original one, but the difference is here the recognition that you actually need to look at the healthcare context as well as these other areas. You have to look at what is happening around leadership in your organisation, about what is happening around healthcare policy. It's what is happening with workforce development. So you need to look at these approaches as well as the other things which I'll talk to you about now. So that macro context is really important. The context in which your organisation works within the healthcare system and what are the influences there, and that needs to be taken into account. But most importantly, when we look at this framework, we look at the prerequisites, the attributes of the nurse. What is it that we want and expect in a nurse that will be able to provide the best possible care to patients and their families? And when we look at these attributes, we want the nurse to be competent, to have good interpersonal skills. One of the things that my colleagues, McCormack and McCann's, have in this is that nurses need to be committed to the job. They need to actually want to be there. Because if you want to be there, you're going to do the best that you can in that place. That clarity of values and beliefs, what's important to me. It's really important that you understand that at an individual level and can work towards achieving that and recognise when that is not happening. So that's important. When we look at the care environment, that's the context in which the practice takes place. So what do we need there? We need appropriate skill mixes of staff with the appropriate skills to be able to take care of the patient cohort that you're looking at. We need to have appropriate development opportunities for staff, etc. We also need to look at the care processes, and these are really fundamental in understanding how we deliver care. That is not only about understanding our own values and beliefs, but understanding what's important to the patient. What's their values and belief system? So if I go back to my friend Adrian that I told you about, his belief is that he is going to get better. His belief is that he has hope and that he does not want to talk about other possibilities. So he does not want to talk that he has a very life-limiting condition, because to do so is too confrontational for his belief system. So we play this game of trying to stay positive in the light of evolving healthcare breakdown. That is working with the patient's values and beliefs. That sometimes can jar against your values and beliefs, but it's recognising where there's a difference in the intersection and being able to work with that that's important. It's also about truly engaging. So when I go back to the story of my mother not being believed, we can see in that story that the nurse was not engaging with that as a truth. And you know, we're all busy in our practice. True engagement does not come from saying, "Do you need anything?" as you're going out the door. It does not mean patients and families see you as constantly busy with no time for them, constantly on rollerblades. Engagement means that you are there for the person, even if that's only for 10 seconds. It is about shared decision-making, the patient, the family, and the staff. It's about providing holistic care, thinking about more than just what's happening in front of you, but about the whole person. And it's about this thing called having a sympathetic presence. And for me, having a sympathetic presence is not about sympathy or empathy. It's about being there to acknowledge for the patient what is happening, or the family of that patient what is happening for them at that time. And to do that, you actually need to be present. That means that when you're in that care space, you need to have the ability to shut all the other things, all the other tasks, all the other jobs, all the other things that are floating through your mind. You need to be able to shut them off and be there at that time, because that's what will make a difference. And if you're able to do that, then we can achieve the kinds of outcomes that we would want and expect for our patients. It's a good care experience. It's about them feeling involved in care. It's about a feeling of well-being, not only for the patient and the family, but for you as practitioners, that you feel as if you were able to deliver the kinds of care that you wanted to. And it is the existence of what my colleagues call a healthful culture. I think they made that up, to be honest. But healthful culture, they say, is about a culture where everyone feels enriched and transformed, no matter what is happening for that patient and family, but also for staff. And that's the difference for me in person-centred practice. This is not patient-centred care only focused on the patient.